Today we'll be talking about breech presentation. So what's breech presentation? Normally we have three presentations: cephalic, breech, and shoulders. So the normal presentation is cephalic, presenting the head, presentation of the head. But in breech, we have presentation of the lower pole of the baby, fetus, to the maternal pelvis, which is the buttocks and or feet, which will be delivered first. So the incidence is 40% at 20 week and 34% at term. We have three types of breech: complete, incomplete, and frank. Complete, 30% is complete, and incomplete. Complete breech, both the knees and the hips are flexed. In incomplete breech, there will be anything rather the buttock presenting, like the foot or the knee. This is considered incomplete. It happens in 10% of the incidents. Frank breech, it's when the knee is extended and the hips are flexed. Also incomplete, it's pêcheur footling. What about breech? So not a cause of concern before 36 weeks. It may change position after that. So before 36 weeks, بس observe lidocaine to see if it changed to cephalic or not. Then maneuvers can be performed. C-section often recommended is تبع lidocaine. Type كان لرضوانتر ديارة frank or extended breech, legs extended, hips flexed. Presenting part, buttocks. The complete or flexed breech, hips are flexed, knees are flexed, both are flexed. Presenting parts, buttock and feet. And footling breech or incomplete, one or both feet or knee is presented. Predisposing factors for breech presentation. We have maternal and fetal. In maternal, fibroid pelvic tumors, these can occupy the uterine cavity, so it prevents cephalic engagement. And contracted pelvis, it's when the pelvic inlet is narrow, it prevents the fetal head from descending and engaging. And uterine surgery, such as myomectomy, so when there's scarring, it alters the contour and it reduces the distensibility of the uterus. So it prevents rotation of the fetus. And also congenital uterine abnormalities, يعني abnormal uterine shapes such as bicorn weight and septate and the other abnormal congenital uterine abnormalities. These also restrict the mobility. The fetal causes or placental causes, in multiple gestation, زمان كما, there's reduced space. Prematurity, so the head is less heavy, less engagement. We will still wait until term. Placenta previa, it's placenta covering the os orifice, so it blocks the head from engaging. And abnormalities, just anencephaly or hydrocephaly. In anencephaly, there's absent cranial vault, so the head is not heavy to engage, and they're incompatible with life aslan. Hydrocephalus, it's enlarged head, so physically unable to descend. So both these are prevent normal cephalic engagement. Fetal neuromuscular conditions, so they cause decrease in muscle tone of the fetus, so it can't move. There will be poor movement. Oligohydramnios, reduced fluid, amniotic fluid, restricts movement of the fetus. And in polyhydramnios, there's increased mobility. So stable cephalic دبتة breech دبتة cephalic, and previous history of breech. These were the factors. Also other possible causes: extended legs of the fetus. چونکە أجر extended بي splinty دكا يعني مثلا أو هاي fetusك أو دستكاني flex دا 20 بس anyways فوتكاني أو هاي extend دا خوي بيو degree and it will splint the rotation of the fetus. And in IUFD, so later عينا there will be loss of tone and movement يعني مردية تبقى an idiopathic ذكر. And diagnosis. Management will start with history. So in history, the mother feels heaviness in the fundus, in the upper part of the abdomen. So the head is heavy and hard, so they'll feel heaviness in the upper part. So as this heaviness, it compresses over the diaphragm, so it causes difficulty in respiration, sleeping, and eating. Also, there will be cord prolapse, because when it's breech, it cannot occupy the whole pelvic, so there will be gaps. So when there is rupture of membrane, there will be sudden fluid gush. تسوكا اشتكنية بفلودا كي بقريتا wide gap man here. So there will be sudden fluid gush. لو لقر أو sudden fluid gush there will be cord prolapse. cord gush لقر دي تخوار. أو أنا the history قلت مان clinical. And clinical examination. On examination كالليوبولد معنا very low دكين. لا fundal we will feel a hard and round. It will be and the feeling will be hard and round, so it presents the head of the fetus. In the pelvic grip, we will feel that it's soft, irregular, and broad. In vaginal examination, we will feel the soft buttocks, sacrum, ischial tuberosity, and genitalia or feet. Also in ultrasound, we can see the fetal lie. Then we will go to the management according to the gestational age and these. So if the patient is less than 36 weeks, we will do ultrasound and assess for the following: the gestational age, amniotic fluid index, for the placenta, breech, طبعا أكيد دكينو كبريتش عنا, and type of breech, weight of the fetus, any anomalies, nuchal cord, number of fetuses. Then at 36 weeks, it may change to cephalic, so we will give an appointment for another assessment after 1 week. If the patient is more than 37 weeks of gestational age, we have 3 management points: either external cephalic, vaginal breech delivery, or elective cesarean section. So all these we will do according to different situations. And now, okay, we'll talk about the external cephalic version, which is the first option. We have more than 50% success rate, 5% revert back to breech, and decreases number of cesarean sections. And okay, preparation of ACV. First, we should be sure about the indication, which is breech. Then, excellent contraindication and well preparation. So the preparation: experienced senior, informed consent, طبعا ده be written consent, exclude contraindications. Okay, بعدين يصير contraindication كان. So in the contraindications اسمها بيلوينا كين: history of antepartum hemorrhage, placenta previa. Mas placenta previa هي بيقر manipulation can will cause bleeding. Oligo or polyhydramnios. لا oligohydramnios, there's too little fluid, so the fetus cannot move أصلا, so it's difficult and traumatic. The polyhydramnios, there's too much fluid, so the fetus moves too easily. Risky cord prolapse man here, and also trauma. The multiple gestations, disanguate man, there's limited uterine space. Previous cesarean mammectomy scar, which we can cause uterine rupture by manipulation. fetal abnormality, hydrocephalus, we cannot rotate it safely, uterine malformations, bicarbonate septate on it's difficult. Turning the fetus is difficult. Preeclampsia or hypertension in pregnancy, the mother is unstable, so we may cause more stress and fetal distress. Nuchal cord, it may cause cord compression. By manipulation, we may tighten the cord and cause fetal distress and hypoxia. If the mother planned to deliver by cesarean section anyway, so section B, declined consent طبعا اگر mother كان نويست اوش ناكين because there's risks. So بابرين اگر هيت contraindication كمان نبو كودس بدا كين. First got man experience senior consent, then we should do a prior maternal and fetal heart rate to make a baseline. Also throughout the procedure طبعا procedure will be under ultrasound guide, so we could check the fetal heart rate throughout the procedure too. And also we should be ready for C-section, CTG before and after the procedure, analgesia, epidural to reduce pain and cause muscle relaxation, tocolytics such as nifedipine, also for relaxing the uterus حتى أسانتر beaten to have less resistance. Brain explanation, written consent, chaperones better too, analgesia, tocolytics, empty bladder أو مهمة, position position a little tilting to the left. Also be ready for C-section, CTG before and after. Procedure of ECV. Explanation of procedure on mango, empty bladder, tocolysis, analgesia, position left lateral tilt. Ultrasound guidance. Also, the procedure should not last for more than 10 minutes. Fetal heart rate trace, also with ultrasound. Disengagement, disengagement of the breech from the inlet. engage بو بريچەکە یەکەم جار دەبی پاڵی دەین disengage کەین. Then the version is performed in the direction which increases flexion of the fetus and makes it to a forward somersault. يعني أما معنى increase flexion يمكن لو أو لا increase flexion so forward دكين أو هاد tilty دكين. To achieve a vertex presentation so as to facilitate the chances of vaginal delivery. كتلتي دكين also we abandon ECV failure or difficulty يعني force ناكين أجر نبو طواو anti-D if the patient لجر ECV we may cause fetal-maternal hemorrhage. So أجر RH negative بو دبي anti-D بدينا تا sensitize نبي. بعد أورس مشتم شاكين the ECV. First mobilization of the breech pilot DSR, then forward rotation somersault low life flexion كيك خوي flex كردي بولا عدا ديبي. Then completion of forward roll later بس وش كردي أجر أو نبو نزحتين هنا لو لا كده كان backward flip لو دكين دي بس لا يباسي نكر lecture anyways. The external version to turn breech. Complications, we have placenta abruption طبعا we may cause separation of the placenta, premature rupture of membrane or trauma, cord accident, cord compression, transplacental hemorrhage or fetal distress, bradycardia or cord compression, rupture uterus or trauma manipulation, failure of procedure, emergency C-section. ECV is difficult in women of overweight or thick abdominal wall, not in has baby surrounding fibroids and deeply engaged breech. So the ECV algorithm, if the breech is confirmed after 7 weeks gestational age, أجر contraindication ما نبو consent ما ورقرت. We will assess for non-stress test and biophysical profile. So اگر همشتك normal بو we will attempt for ECV. اگر successful بو continuous vertex أو دكين vaginal delivery يعني vaginal delivery طبعا section بي أصلا ECV لو ناكين. اگر revert بو low breech أو يعني ببريتش C-section لو دكين يعني ببريتش vaginal breech delivery لو دكين. اگر unsuccessful بو نما طاين ECV لو بكين consider retrial ديسان لو بكين الزور ناكري طبعا أو يعني C-section لو دكين يعني vaginal breech delivery عينا هذا كينو آخر شي. So management of labor or vaginal breech delivery استعجيشنا delivery أجر vaginal breech delivery ما انكرت تسدكين. So we should carefully monitor the fetus and the mother by continuous CTG. For epidural analgesia, it's not essential, but it may be advantageous. يعني speedrun. For reducing the pain of the mother and prevent pushing before full dilatation to help control contractions. حتى maneuver كان آسان تربكين. And also we could do fetal blood sampling from the buttocks, bloody buttocks account where they're green, and assess for the acid-base status to detect fetal hypoxia early, especially when the CTG is abnormal. There should be an operator experience man heavy and case selection يعني لهم case ناكين طبعا vaginal breech should be frank or complete flex استباش لكن بديتيل not more than 3.5 kilogram flexed head adequate pelvis no anomaly. So fetal-maternal presentation should be either frank extended hips flex knees extended يعنيش complete flex هردو كان flex بي but feet not below the fetal buttocks يعني نابي footling بي incomplete flex بي incomplete breech بي مقصدهم. There should be no evidence of fetal pelvic disproportion. There should be adequate pelvis, fetal weight not more than 3.5 kilogram, and there should be no evidence of hyperextension of fetal. There be headache, flexion, be complete flexion, and no fetal abnormalities, congenital anomalies. It's just hydrocephalus, severe hydrocephalus. Mechanism of labor. The lie should be longitudinal, presentation breech, denominator sacrum. The engagement, bitrochanteric diameter, descended, internal rotation, lateral flexion of the trunk to help deliver the shoulders. The arms should be flexed to be delivered to prevent obstruction. If extended or maneuver low sets maneuver the flexed head is engaged in a transverse diameter, head delivered with the face being swept over the perineum. هذا كده flex cane. We may do it with Mauricio Smelly-Vite maneuver. So first we should confirm fully dilation, rupture of membrane, empty bladder, experienced one, and then the technique. The technique, it's usually hands off. يعني عندك أساسي تكين طبعا بيبيك وازنين بخوي بتدري بس أوني بري راش جشين. We should not pull the baby and speed up the process. This will cause problems. So hands off till spontaneous delivery of the buttocks. When the buttocks are delivered طبعا كده design we will see anus, meconium and sacrum. When the anus seen we could do episiotomy يعني it's selective. We could do episiotomy but not يعني after we see the anus not before. So around the buttocks. Then we have the legs. If the legs are flexed there will be spontaneous delivery. If they are extended we could do Pinard maneuver by doing pressure on popliteal fossa causing external rotation at the hip joint and holding the ankle and flexing the knee. So if the legs are flexed spontaneously, extend Pinard maneuver with contractions and maternal for the lower body will be delivered. And usually a loop of cord is drawn down to ensure that it's not too short. And أول فيديو تمشاكين for the Pinard maneuver. Look, here the legs are extended. So, and they will act as a splint and will not allow delivery. So we will insert our hand through the thighs and go in and hold from the popliteal fossa. And then flex the knee and hold from the ankle and assist for delivery of the leg. And again for the other leg too. So اگر بين ليرش تمشى كين لسه رسمة كي أولا Pinard maneuver, holding it from the popliteal fossa. Then we have ليرش دي سان رسمة Pinard's maneuver. Then we have delivery of the shoulders. In the delivery of the shoulders, baby will be lying with the shoulder in transverse diameter of pelvic mid cavity. As the anterior shoulder rotates, in the anterior posterior diameter of the spine or the scapula will become visible. A finger gently placed above the shoulder will help to deliver the arm. يكم ذلك anterior shoulder كهات anterior, the scapula will be visible, and handك أساسي دكين, a finger gently placed above the shoulder and will help deliver the arm. arm Then there will be spontaneous rotation of the posterior arm. Posterior arm جديسان أو جدي توسري دبتا anterior. هردو چیان دبیلا بنت پیبیکی بینه داره تکلم در آسانترا. Reach the pelvic floor to and rotate anteriorly in the opposite direction. So once the spine becomes visible, delivery of the second arm will follow. A rocking boat with one side moving upward. يعني بدستي هندق هذا يصلون ديزورين أولا أو pedal a rocking boat, so that it will assist the delivery of the arm. We will avoid unnecessary pulling. يعني رانا تشين. And ليش نسيت مام. Baby back should face you. يعني لهم holding backy روي لما بي. And أو زارهات ينسر أو طبعا أجر armaka أو أبو flexible. أولا قلت أجر armaka flexible. أجر arm if the arms are extended. You'll do love sets maneuver. أي مكتي أو شرحها عندك إذا عادة. أي مكة أوي ك anterior shoulder يعني أو shoulder إذا ما نبي الندرة بكين anterior أو زبيه الندرة. So anterior shoulder طبعا أوي ك لسريلة in the pubic symphysis, below the pubic symphysis. So لسه أورس ما يشرح كين. Here in step 1 we see that the baby's shoulder are stuck, extended. Then in step 2 we will assist by a hand. I'm holding the baby with in their buttocks, not the tummy, not the abdomen. And by a hand we'll assist the delivery of the arm by holding it in the joint. Then in step 3 until the anterior arm. Then we will rotate. In step 4 تمشاك rotate, and in step 5 بتوعي rotate كردي ديسان أو زارة the posterior arm now became anterior. Now we will also again the same way will assist the delivery of this anterior arm too. So step 6 So this is a video about love sets maneuver. The back facing up. Then when the shoulder blade is seen, we will rotate the baby, making the arm anterior, and assist the arm by holding it from the joint, not from the humerus, because it can cause fracture. Then making the posterior shoulder anterior, just like that, rotating the baby, and then again the same thing, assisting it from the joint and bringing the arm out. Our love set maneuver. Now we have the delivery of the neck. We will give time for delivery of the neck, about 1 minute. Then we have delivery of the head. The head is delivered using Morisot Smelly White maneuver. how we will put our dominant hand, the middle finger of our dominant hand, in the mouth of the fetus, and both the index and the ring finger on the maxilla, on each maxilla of the fetus, and also traction downward, flexidacane, traction downward with the dominant hand. With the non-dominant hand, we will hold both the shoulder of the baby, the fetus. Then the delivery works with first downward and then upwards movement, as with the instrumental delivery. يعني first downwards, then upwards movement. If the maneuver proves difficult, if the Mauriceau Smellie-White maneuver is difficult and we couldn't deliver the head, we may use assistant of instruments, just forceps. By an assistant will hold the baby's body upwards while the forceps are applied in the usual manner. This is also the Mauriceau Smellie-White maneuver. The maneuver is jaw flexion and shoulder traction. So here we can see jaw flexion and shoulder traction. And this is the forceps. If the maneuver fails, an assistant holding the baby, holding it upward like this, and assisting with the forceps to bring out the head. Now, we have complications of a breech, labor, and birth. So we have increased risk of cord prolapse, particularly with foot-link breech, increased risk of CTG abnormalities, the cord compression, the fetal hypoxia distress, mechanical difficulties with delivery shoulders and raft head, damage of the visceral organs or brachial plexus. طبعا difficulty معناها baby كده. Delay in the delivery of the head, which may occur with a larger fetus. If the fetus is large, there will be delay in the delivery of the head and lead to prolonged compression and compression of the umbilical cord and hypoxia. If the baby is smaller, the smaller fetus, there will be uncontrolled rapid delivery. When there's uncontrolled rapid delivery, اشتك معناها دبتة tentorial tear in the intracranial, and it will cause intracranial bleeding. A small or preterm fetus, which may deliver through an incomplete dilated cervix, on head entrapment. If the cervix is not fully dilated, then there will be head entrapment. And then if it's prolonged more than 4 minutes, it will cause hypoxia and CP, cerebral palsy. So in head entrapment, we will make a tear by symphysiotomy. And yes, summary. Thank you.